All right, good morning officially. My name is Christina Frederick. I work here at Franklin County Public Health, and for the last 3 weeks or so, I have been overseeing, I guess, the clinical aspect of the home visiting and phone calls for our isolation and quarantine population. So I want to thank everybody again, officially, to volunteering your time and effort to come and sit and find out what public health has been doing the last several weeks. Because as our numbers of positives grow, our numbers of people that we are monitoring grow, usually exponentially. And it gets very difficult for within public health to manage those people because we have such a limited staff of people. So thank you. So I just wanted to go over really quick. You hear the term isolation and quarantine. Sometimes you hear them used interchangeably, but they really are two different things. And really the easiest way to keep it straight in your mind is quarantine are for healthy people and isolation is for sick people. And they mean two different separate things. I still have to step back and sometimes guess, not guess, but second guess myself, am I actually identifying this person as what they are supposed to be? So quarantine is somebody that is healthy. They may have been exposed, but they are showing no signs and symptoms. They are healthy people, but they are still asked to quarantine away for those 14 days possibly, because if at any point during those days they may start to show signs and symptoms. And isolation is somebody that we know about that has been exposed to a positive, a direct contact, and they are sick. And they are staying at home and away from others. So just an easy way, quarantine are healthy people, and isolation are people with those signs and symptoms that we are interested in, and those are the people that we are starting to fill up with as our positives grow. So just as an easy kind of, they're not interchangeable, but it does get easy to kind of mix them up. And I quickly wanted to go over also, a lot of people already know this, the classic signs and symptoms of the COVID-19 virus. We are mostly interested in the fever, the cough, the fatigue, the shortness of breath, those respiratory symptoms. COVID-19 is a respiratory virus. It's going to attack our respiratory system. However, within that, we are also seeing some other symptoms such as the headache, a nasal congestion. So they're not runny nose and they're not blowing anything out or coughing anything up. It's just severe nasal congestion, a sore throat, I said headaches. Sometimes they are coughing it up. Sometimes they are having shortness of breath. The chills, the pain in your muscles, those symptoms like a fever, like you feel achy, and nausea and vomiting and diarrhea are also kind of these not so classic symptoms of COVID-19, but still are nonetheless symptoms of COVID-19. So it's just good to be aware of these. So as you're visiting and as you're talking to these people, if they say, hey, like I just, I have this awful headache, my throat is sore, then we may start to progress to, okay, we need to start monitoring this person a little bit more because they are a higher person of interest, because these are early on sometimes symptoms of what it's going to progress to. So it's just good to be aware of what kind of those not so classic symptoms of COVID are. So I'll start off with phone calls because really phone calls are the basis to this to begin with. And once you get phone calls kind of under your belt, home visiting is the same thing. You still are on the phone with these people. We don't come into contact with them because if we did, then we would be out. So we're not coming into contact with these people. We still are on the phone. We're still maintaining our social distancing because, and also ultimately, we want these people to stay in their bedroom. We want them to stay where they are quarantined and isolated. So we don't want them tramping through their house, touching all of their light switches and doorways on the way in and out. So oftentimes when we do our home visiting, we're watching these people from their bedroom window, or we're walking around their house to their bedroom window that's, you know, in the back of their house. Like, we want as much as possible to be able to to keep them where they are isolated as opposed to coming to us from their home. So a lot of times we are on the phone with them as we're making our visual, or moving, you know, from the top window down to the driveway. So phone calls and telephone is really a good basis for this. So hopefully everybody has a good, like, solid on cold calling and just being able to talk comfortable on the phone with these people. So really simple. I gave everybody what a daily monitoring sheet will look like here. People on the call, I will get that out to you as soon as we're done. But this is what our daily monitoring sheet looks like. It is fairly simple. It is, if you're making a home visit or if you're making a phone call, you document it. It's the date and it's the time of day that you were there. You put whether they were responsive to questions, if they were cooperative, or if you weren't able to get a hold of them. And then you document everything that you asked. So we do try to reach out twice before letting a supervisor, myself or Patty, know that you were unable to get a hold of that patient. Home visiting, they should be home. They are under isolation. So if they're not home when you stop in, that is a huge issue. You automatically will reach out to Patty or myself. But for the phone calls, they could be sleeping. I mean, they could be in the shower. These people are still able to have, you know, those kinds of lives. So reach out a second time, and if they don't answer the second time, then reach out to a supervisor. And I just went over that. So one of the biggest things that we want to know is what their temperature is. So we ask on the phone, all right, do you have your thermometer? You will sit there and you'll, for that minute or two that they have, you know, that it takes for a thermometer to read their temperature, and they'll read it to you when it's done and you'll be able to hear it beep. A lot of our people that are, you know, on day 9 and 10 and 11 of us calling, they sometimes take their temperature in the morning just so you're not like dead silence on the phone with them while they hold the thermometer in their mouth. If that is the case and it has been, you know, no temperature and they've been fairly steady and not symptomatic, that's fine. Just write down their temperature and the time of day that they took their temperature. So we know about when it was taken. And for those that we only contact once a day, we will be asking what their temperature was the night before. So they are still required to take their temperature twice a day, but we only call and it's reported to us only once a day. So those, and you'll know those people, they're PI or PQs. You will know that those only are once a day phone calls. We don't visit them, and you will know to ask about their temperature from the night before. So what are we asking these people when we get them on the phone? Oh, did I miss a slide? Okay, I did. I want to go back to this slide. So if they do answer, I first and foremost say these are people, these are our friends, they're our colleagues, they're our community members. I don't always just jump and be like, so what's your cough, what's your temperature? There's a human aspect of this. And a lot of times people on quarantine and isolation, they're anxious, they're alone. I mean, you may be the only person that is calling them or in contact with them. So really it's a friendly voice. It's a human. So how are you feeling today? You know, what's going on? It's a conversation. And I like to remind everybody of that because, you know, we are in human services. Even though it's over the phone, we still need to have like a smile on our face when we're talking and have it be a pleasant encounter. And again, like I said, these are our friends, they're our community, and we need to know that, and they need to know that we are taking care of them, and we care also. It's not, oh, I have 50 of these phone calls to make, like, and this is number 49, like, let's get this over with. It's, you know, every time it does get daunting, but it's appreciated at the same time. So I want to just put in my side note. So cough. So we are asking these people about the cough, and it does go right through on the daily monitoring, their cough. Do they have a cough, yes or no? And what is important with this is the follow-up questions. It's not so much if they have a cough, yes or no. Yes, that is what we want to know. But we also, the follow-up questions are super important for this, because did they have a cough yesterday? Is this a new onset of a cough? Like, do we need to really think about, is this person getting worse? Or do we need to get them tested? So, how long have you had this cough? When did it start? What is it like? Are you spitting anything up? What color is it? Do you normally get a cough this time of year? This is allergy season, so we are getting a lot of people that are like, I normally have congestion, but I have allergies and I am taking medicine for it. Well, is the medicine working? Like those kinds of conversations, all the follow-up questions that, really get us the information that we need to be able to better care for these people in our population. If it comes to a point where any of you do not feel comfortable with the signs and symptoms that any of your people that we're requiring you to see, you need to bump it back to us, and Linda, myself, Peg, will be able to take those people on. Okay, I don't want to send anybody to answer questions or go into a situation that they don't feel comfortable with. And the community, the people that we're seeing don't want somebody that's unsure of themselves either, because of course in a time with high anxiety, that's not going to help their situation either. So if at any point, if you guys come to a person that just every day has multitude of questions, and just you can't get their anxieties under control, just bump it back, let us know, okay? And of course, document everything that they tell you on the phone. So one thing that we're asking also is about shortness of breath. Do they have it or not? And of course, those follow-up questions, when did it start? Do you normally have shortness of breath when you walk up the stairs, or are you generally okay to walk up the stairs? Do you have any, underlying medical conditions where you normally are short of breath, like COPD, asthma, allergies? Do you feel lightheaded? Do you have to use an inhaler? Have you been taking any medication for this? So shortness of breath and those follow-up questions that go along with it. When did it start? Those kinds of things. Sore throat. Simple yes and no. And when did it start? Does it hurt when you swallow? Are you able to eat? Another thing we're seeing more recently for our positive cases is they're reporting like a loss of smell and taste. So just something to be aware of that can kind of go along with a sore throat, like loss of taste, not being able to taste things, nasal congestion, but they weren't reporting sore throat or nasal congestion, just the loss of taste and smell. So just those little things to be aware of like early on before onset of severe signs and symptoms. Any other respiratory problems? They talked about COVID-19 being a respiratory disease and virus. It's going to want to affect and maintain in your respiratory system. So runny nose, nasal congestion, some people reporting a heavy or tight feeling in their chest, not being able to take a deep breath, and documenting everything that they are telling you. And other symptoms we talked about earlier that aren't so classic of COVID-19, but of the respiratory classic symptoms for COVID-19, but patients reporting a headache, the pain in muscle and joints, chills, those signs and symptoms usually of a fever, but may not have a fever at the same time, and any nausea, vomiting, or diarrhea, and of course document all of these symptoms. And then it just goes to kind of a summary, I guess, of your phone call or your home visit. So has the patient answered yes to fever, shortness of breath, sore throat, any other respiratory symptoms or any other symptoms that they're experiencing. If they answered yes to anything that you had asked them, then you have to say, yes, this patient is symptomatic. And we need to, and that gets reported back to us, of course, and then we kind of determine what we're going to do with that patient at the end of the day. So also at the end of the phone call, we take it back to having a conversation about that person and their needs. Do you have enough food? You know, what can we help you with? Do you need more Clorox wipes? Are you cleaning your house good enough? Are you cleaning your bedroom good enough? The bathroom good enough? Do you need help with those? Ultimately, if somebody else is in the house that's not under isolation or quarantine, we do try to have that person meet their needs prior to public health trying to meet their needs, just so it's not such a burden. But sometimes people live alone and they're isolated in quarantine and can't go out. Some of the older population isn't, I guess, as savvy like Instacart or ordering groceries online to get them delivered. So they may need just somebody to walk them through that process. You know, they just, whatever needs they have met, that should be of our help, and so not on their anxieties, which they already have. And also, I always end my conversations with, not that one. Do you have, yes, this one. Do you have any questions or concerns? What questions do you have for me? Do you have any questions for the nurse at public health? What are your concerns? And usually it's like just a conversation. Sometimes it's no. Sometimes these phone calls take like less than a minute. Sometimes you're on the phone with them for 20, 30 minutes. It just depends on that person, what their needs are, what their thoughts are of the day. If they do have questions or concerns, you can give them public health phone number, which it's at the end of the PowerPoint. You can give them my direct phone number. You can just give them, at the end of the day, you can give me their information and I'll reach out to them. It's however kind of that person is okay with accepting the help, the questions, the concerns. So daily reporting. Every day, I do need a report of who you were able to visit or call or who you weren't able to visit or call. And that allows me to know that everybody on our isolation and quarantine had a conversation with, and it gives me a chance to review how that person is doing that day. Like I said, we want to catch these people early for signs and symptoms. We have some higher risk people on our cases where not everybody is being tested right away. We kind of hold them on isolation and quarantine. If their signs and symptoms get worse, then we advocate for them to be tested. Unfortunately, we are in a state where testing kits are hard to vouch for. So we really do have to kind of prioritize who we are going to be testing and who we are not going to be testing. It's not an easy, way of doing it, but it is what we need to do to make sure that the appropriate people get tested. But ultimately, they're under isolation and quarantine, so they shouldn't be in contact with anybody. So really, even if we get them tested and it's a positive, it shouldn't make a difference because they shouldn't have any contacts. They shouldn't be leaving their home. All of these things, what are the basis of isolation and quarantine are. So even if they're negative or if they're positive, it really shouldn't matter. They should still have the same practices. We should be treating them all the same. Patty says it, and now I've caught myself saying it. If they are sick, then we are treating them as if they are positive. If they are sick, they are sick with something. They need to be isolated. They need to be quarantined. It doesn't matter what they have. We're going to assume the worst because that is what we are living in right now and dealing with right now, and trying to combat. We're trying, I'm sure you've flattened the curve. We're trying to flatten the curve, and that's really what the basis is. If you are sick, we are going to assume that you are positive and you need to go in isolation and quarantine. The home visiting aspect of it is literally The same. It's the same conversation. It's the same questions. It's the same reporting form, except you are in their driveway or you are in their lawn, and you visually see them taking their temperature, and that you visualize them in their room or in their place of quarantine. So like I said, we're not coming into contact with these people. We can't come into contact with these people because then we are ourselves on isolation and quarantine, and we can't wipe out the small amount of people that are working. So really, I know some of you have worries, I guess, about the home visiting aspect of it. But like I said, we're not ever in close contact with these people. So right now, Peg, do you have anything to add?
No, I think you've covered everything. I think you've covered it pretty well.
Okay. Linda, do you have anything to add as a home visiting guru?
No, but I think that personal touch is really important because these people that we contacted are scared. So we ask them their questions, but we also communicate with them. Sometimes these home visits can take 4 minutes, sometimes they can take 20 minutes.
I'm sorry, I can't hear her.
Can you?
Sometimes people have questions.
So come closer. You may have to repeat all of it, Linda. Sorry.
Sometimes what Christina said about the personal touch, it's really important because people are nervous, people are paranoid, they're hearing things that aren't correct. So you treat them like you.
There are friends, there are community,
you answer their questions. Sometimes these are quick visits when you pull in. Sometimes they're 5 minutes. Sometimes it's 15 minutes because they have questions. And we do ask them about their needs. We are providing thermometers if needed. We are providing Clorox wipes, soap. We are asking if they need services from the community. But most people are pretty receptive to us coming and then us calling in the evening for the people that need to be done twice a day. Thank you.
So on the initial visit, we bring a box of items like Linda said and leave it at their door. And then we back away and get in the car and contact them.
Yeah, it is surprising how many people don't have thermometers to be able to take their temperature at home.
And they're very appreciative of those boxes, I can tell you.
So this is Patty, and Chrissy, I think you did a great job with summarizing things. The only other thing that I really want to express the importance of is we're really working hard to try to still contain this and flatten the curve. And many of these people, I mean, 80% of people who actually develop COVID or are infected with it will be able to stay home without any problems. And that's really what we want them to do. But there are a certain percentage, 15 to 20% that may develop problems that end up in the hospital. And that's where it will put the tax on our healthcare system. And we are trying to flatten that curve so that as people go into the hospital, we don't overwhelm our hospital system and collapse it. So I have to reiterate the importance of when you ask about those needs. If someone is needing something, really kicking that back to Chrissy so that we're making sure that if they don't have a family member that's bringing them food, that they don't have some ways of meeting that needs and still maintaining their isolation, that we are addressing those needs. And Chrissy has the resources to be able to do that. So we don't expect you necessarily at the home to deal with that, just to ask, can someone bring you food? Or is this something we're going to need to help you with? And just communicating that back to Chrissy. But also having that conversation with them and making sure that they are staying in their bedroom, that they're not going out to the other parts of the home, that they're still able to get food from the kitchen to their bedroom. You know, we don't want somebody sitting in their home and saying, well, I can't go out to the kitchen, so I can't eat. But because no one has said to them, how is that going? They've just assumed that this is what their life is, and that's not what we want for them. We need to figure that out. So anything that is a problem, kick back, and we will address that on a one-on-one basis. But making sure they're maintaining that quarantine and that isolation is extremely important. And documenting that. On the back of the forms, there is a place to document that they're maintaining compliance with the isolation and quarantine. On one of the forms there are.
This is Chuck. I just have a question about what's the current caseload?
Yes. So right now we are, knock on wood, any second it could change.
Yep.
Right now within public health, we are able to maintain our current caseload. Currently we have 23 on quarantine and isolation. So it's not, but last week we had like 64. So, you know, a lot as they time out, you know, they go off quickly, and as results come back, they could either come off or as positives come back, like I said, and we do that contact tracing. Exponentially, the amount of people that we are calling and providing home visits to could change overnight. So right now we're maintaining, but we don't want to just maintain. Like, we want to be able to have a day off and, you know, sleep. And so that's why you guys are super important in this whole maintaining, because we don't know how long this is going to go on for. But every action that we take now, we're hoping that it does become shorter and shorter.
This is a marathon, not a sprint.
Correct.
Got to keep you guys healthy too.
Correct.
As far as volunteers, what qualifications are you looking for?
We would like volunteers in the healthcare field, but we're not limiting it to just healthcare. Willing, I guess, would be a good, you know, just anybody that's comfortable also, because we don't want to be sending somebody to a home that, you know, somebody that has anxieties and sending them somebody that has equal anxieties about doing home visiting. So somebody that's comfortable making cold phone calls and having conversations with people they don't know and making it sound like it's a personable relationship. And home visiting, you know, going to somebody's house that you don't know and walking around their yard to try to find what window their bedroom is. I mean, that, you know, that has to have a certain level of comfortable, you know, that you, for home visiting. So.
As long as you come bail me out after I get arrested for peeping through people's windows.
I didn't say peeping. Yeah. Oh, safety. Yeah, so safety is a large issue as we do venture onto these people's private properties. You know, safety is a huge issue. Dogs are a huge concern and always are for home visiting. So, you know, just being aware of that. And safety also, because like I said, we don't want to come into contact with these people. We don't want to touch their doorknobs, you know, as possible exposures. So you need to think about yourself, your family, because as we're out there doing this, we're going home at night, and we want to protect our families.
And don't forget that it's important to make that phone call when you arrive. If you're making a home visit, you're making that phone call when you pull in the driveway. And that's a great time to say, you know, do you have a dog? Is your dog inside? Could someone make sure the dog is inside or tied up, confined, so that you're not encountering those animals as you're getting out of the car? So you can have those conversations on the phone, and then you can walk around and watch them take their temperature and say hello. You don't have to have the whole conversation while you're standing outside on a phone looking through the window. So, you know, you can kind of sit there in your car and have that conversation. The whole purpose of going to their home unannounced is, again, to make sure that they're maintaining that quarantine. If you show up there and they're gone because they didn't know that you were coming, then that's a second check to say you're not maintaining quarantine. And these people are read the voluntary quarantine information upon the first contact by Chrissy usually, and it's reiterated, and they are made aware that if they break the voluntary quarantine, then we may have to pursue a legal quarantine, which forces them through court orders to be maintained in their home. And so that's important. If you're finding that you're like, you know, I don't think they're maintaining quarantine, I am not feeling good about this, kick that back, because we're going to have to do a little more to make sure that they do follow the quarantine and the isolation.
My impression is, luckily, that most people are maintaining the quarantine. Is that right?
Yeah. Yes, that's correct. We haven't had anyone that's non-compliant. We did have one particular person that was pretty insistent that he quarantine with his partner, which was in a different county, but he had a legitimate reason. We spoke with that county, and they were able to quarantine together. They had traveled, so they didn't have any symptoms. So we've had some kind of questionable ones that we thought maybe wouldn't, but they turned out okay.
Any other questions?
This is Beth Landon. I have a question about status. You mentioned that the people who have isolation orders are asked to stay just in their room. I wanted to clarify if we have patients who live alone and they live in, you know, 2 rooms with a bathroom or something like that, you know, maybe a bedroom, a kitchen, and a bathroom. Do we still advise them not to do their own food preparation, or?
No, so if they are living by themselves, they can have access to the whole room. What we are telling people is the importance of cleaning the surfaces after they're done using it, even if they're the only person. Because remember, this can live on surfaces for a certain amount of time. So as they're coming off, we want to make sure that those germs are kind of cleared up. So instructing them on cleaning the countertops, the handles in their home.
Right, to decrease viral load, et cetera, and secondary infection.
Correct.
The other question is, I would think that you would have for each case a contact, whether it's a neighbor or a family member who doesn't live in the residence, or are those data collected and are they useful for you?
So I just want to clarify what your question is. So you're wondering if we have to collect information on maybe the neighbors for a contact for them? Is that what you're asking?
Yeah, do we have someone that is not a co-resident, or maybe a co-resident, but who we could contact if we call the patient and get no response?
No. So if we didn't get a response, if you didn't get a response, kick that back to Chrissy, because probably what we would do at that point in time is we would drive to their residence. Sure. Because again, it could be a situation and maybe they're not in a good position. We'll have to figure out between our EOC and ourselves how we make sure this person is okay.
Great. Okay. That's helpful. Thank you.
And I don't know if I said it earlier, but all of the people that are on our cases, our caseload, we really try, HIPAA and confidentiality is utmost importance. We can't talk about anybody that we're going to see to any neighbor. You know, if the neighbor comes out, you can't talk about why you're there. And you can't talk about it, in a very, if it's an apartment complex, you're going to have to be creative in how to figure out how to maintain their confidentiality. So really, that is utmost important to us. And just
of course, there's a concern about stigmatizing and et cetera.
Absolutely.
Yeah.
Yeah, but you're going to have to come over there.
So do you have some suggested lines that you've used that you feel comfortable with?
As far as?
If a apartment neighbor says, "Hi, what you doing? What's your go-to line?"
So I usually just say, I was here for a visit. I'll come back later. They don't need to know who I am. They don't need to know where I'm working from. Just a visit.
Great.
This is Linda Smith again. I just wanted to add, if you're in your car and you're talking to the person, turn your car off because your Bluetooth, you can hear outside of the car, especially when you brought up the about being in an apartment complex. Yeah. Turn your car off so the phone call is private, because I don't know if anybody's ever heard walking by a car, you can hear the whole conversation, so that kind of breaks the HIPAA. Yeah. Okay? Yeah, I don't know how to work mine yet. You don't know how to work your Bluetooth? I haven't set up my new phone.
Any other questions?
Yeah, I bet it is, so just say it. I would have never thought of it.
Okay.
No, this is helpful. Thank you.
How are we going to get assigned?
How are they going to be assigned?
So I now have email contacts for everybody. Does everybody check their email regularly?
Yes.
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 Okay. So
if you would like to add my wife Beth, who's a retired PA.
Perfect. Wait a minute.
Her email address is bvananden@gmail.com.
Perfect. So what I've been doing for our county staff is when I get a new one, I shoot it via email, and a little synopsis of kind of what the case is also and what you would be required to do. So one call in the PM, or one call a day, whatever time your heart wishes. But I do try to give a little synopsis of what you're walking into also, as much as I know at the time.
Good.
I would also just like to say that especially for the apartment complexes, sometimes you can see the person at, you can park by the road and you might be able to see them from your car in their window. And that's okay to completely do that visit, in your vehicle, if you can see them in their window. And then someone's not just kind of standing outside some of these apartments, and of course, all the neighbors will come out at that point in time. So just kind of thinking about, as you're on the phone with them, asking them, when you look out your window, what do you see? What street is that? And kind of parking where they're seeing that street so you can then see them. So just some of those creative questions might need to be asked before you get out of your car and kind of figure out where you need to park in certain circumstances.
And as we do more of these, we are trying to get better with our initial phone calls, which Linda makes, myself makes, Peg, you make some of these initials. And so now we're learning to start to ask those things. So when we're in the driveway, we're not now asking, oh, how am I going to see you? So we know going into a situation how we're going to make contact. So it's a huge learning curve for us as well. And as you make phone calls or do the home visiting, please share any learnings that you come across also. Any other questions?
Have you run into any particular issues that you kind of stump you? What have been your learnings while you've been doing this?
I think the apartment buildings was a kind of an obvious learning curve, something that we didn't think of going into it. That was one for me, Linda. Oh, yeah. So long driveways, you know, those kinds of things where, yeah, where you're going to have to possibly walk up the driveway because your car is 2 inches off the driveway and, you know, there's rocks sticking out, so you're walking up these driveways. No cell service has been an issue for us, because how are you supposed to call these people and talk to them when you have no cell service at their house? So that's been interesting. I think obvious ones so far, that normal kind of home visiting you run into.
I think we really have just learned the first visits I made myself, and initially we were told to go into the home. That was kind of our guidance from state down. And we made the decision that we were not going in the home. I just didn't feel comfortable. And not only that, but people were not feeling comfortable. Extreme anxiety with us going into their homes as well, because their concern is, if I don't have it, I don't want you bringing it because I know you're going to other homes. So I think we've learned, you know, a different way to do home visiting other than in the home. And in this circumstance, it seems to work better for both nurses and patients.
I have a question. On visits that you have to make a home visit, do you call ahead and let them know that you're heading over?
No, so we wouldn't want to do that because we want to make sure that they're maintaining quarantine. And so they should be there when we arrive.
So if there is no cell service, how are you supposed to alert them to know that you are there to do a visit?
So you find out literally like the last second that you have cell phone service and call.
Okay.
Yeah. So I am, whatever, 5 minutes from your house.
Okay.
And if that doesn't work, you may have to, you know, drive up, honk your horn. Again, they know to expect somebody when we have a conversation with them on the phone. And if you drive up and they honk their horn, just kind of be looking at that window, see where they're at. And then you may have to get out of your car and go up to it, ask them to open their window so you can have that conversation with them. We don't want you going into the home. We don't want them coming to their front door and opening the door and having that conversation face to face. But most people are able to at least open a window and have a conversation. So just kind of getting creative with when you make your call that you're there, and if not, you might just have to honk your horn and kind of figure out, kind of be a little mini detective person.
I have found that most people appreciate you checking on them.
Mm-hmm.
So some people, when they get older than me, they start having hearing problems, and they have trouble on the phone and even trouble in person. Is that ever an issue? Anything you've experienced on that?
So here in Franklin County, we have not seen the trend of having the older population being the ones that are most at risk, I will say. We have found that it is middle-aged, younger. There have been a few that have been older, but most of the people that we are following are middle-aged and younger. So we haven't really run into the a majority of our dealings with an older population.
Now, if the younger couple, they both show symptoms in their isolation, what if they have younger kids that can't provide themselves with food and stuff? What do you do at that point?
Yeah, so we'll try to give you the guidance on that as each case, because each one of those cases we have to really work with the state. sometimes it comes to a point where we have to say to them, is there someone else that can take care of your children? We haven't gotten to that point as of yet. We're very thankful. We've been able to kind of keep that family structure together, but we may come to circumstances where we have to have the children taken care of by someone else outside of the home. It may come to the circumstance where we have to remove the ill person and put them in a hotel so that their family can still isolate separate from someone who's showing symptoms. So as we come across those cases, we'll keep you as up to date so that you know making those visits.
And then a couple who are both in isolation, should they be in separate rooms?
Yeah, so far, the guidance has been, if you're both sick, you're still sleeping separate. We haven't had an instance where we've had 2 positives in the same home yet, so that could change. But 1 positive and someone who's showing symptoms, we still say stay separate because one could have it and maybe one has something else. And so we're trying to get those people tested as soon as possible, but the guidance is still they have to sleep separate and have separate bathrooms, or if it's the shared bathroom, the mask when you go to use it, and the cleaning of that room before you leave.
So there are some people who have been coming back from traveling who are self-quarantining. And is there, do you want to know who's doing that? And do you want to informally follow them? Or what's your take on that?
So for those who have traveled outside of the country, we're supposed to have a notification system in which we're notified, and then, yes, we are supposed to be quarantining them and following them ourselves. We don't have that directive for those who have traveled within the U.S. As of yet, but everything is changing so quickly. So it's just, we could even put them on a tech staff if we knew of them, especially since I'm assuming they're not ill.
What's a tech staff?
So, yeah, New York State has a tech staff in which we can put names, date of birth, and addresses of people. And each day they receive a message, and it pretty much says, you know, do you have any symptoms today? If yes, it allows them to enter in their symptoms. It asks them to enter in their temperature and things like that. And then we're able to go on each day and take a look at that particular information.
And a personal question. My thermometer, its battery has run out of juice. Do you know where I could buy a battery? Because they're not on the shelves here in our drugstores.
Only thing I could say is to check Amazon and check your online stores as well. But that is the problem we're running into, is no one can buy a thermometer that is under $60 from the store.
Closure. Beth and I are now on day 8 of isolating ourselves post international travel.
Oh, okay. So I wasn't made aware of you guys. If you like our
Beautiful voices to call you every day. We will.
I don't sense because it's not a, well, if for legal reasons you need us to report that, we can. I feel like it's, given the circumstances and how much data is going to be collected, and because both of us are health professionals who have sort of familiarity with what is important in this setting, I'll leave that up to you. We want you to do what you feel is consistent with your guidelines. But
right. So
and
the
if you want
guidelines.
next step, we can.
Okay. Well, I think, you know, we now have daily contact, or we have contact with you. You know the rules. If you're not symptomatic, I'm okay with you guys, you know, self-monitoring. I don't think we need to make a big deal about that. But if you develop symptoms, that would be something we would want to know. So making sure you're able to reach out to us if that happens. But also, the guidance for someone who has traveled is that they should not be leaving their homes, and they should be self-isolation. So for you guys, we would have to be able to have you do phone calls and not home visits until your quarantine period is over.
Definitely.
Yeah, so next Thursday, we're done.
Okay.
But we're happy to make phone calls.
Okay, thank you.
And we have been,
Perfect. Any other questions or comments?
At this point, Lindy would prefer to be making phone calls. I'm an engineer. I'm not a medical person, but I'm logical enough that I think I can do the phone calls.
Perfect. All right. Any other questions for? Okay. So up on the screen are just some important numbers. They are hotline numbers. Alice Hyde Medical Center has their own hotline. Our EOC has their own hotline. AMC has their own hotline now. And Office for the Aging is a good resource. They are stepping up to deliver meals to anybody that may need it. Qualifications are out of the water at this point. DSS is there for assistance for those that need assistance with food and are out of work, and they are working around the clock over there. And also the crisis hotline for all of our mental health issues that we may come across here in Franklin County. I will share this PowerPoint so everybody can get the numbers for those of you that are on the WebEx, okay?
Great.
excellent.
All right. I think the last slide is
Also, the local school system here in Saranac Lake is delivering food to families with children every 2 days.
very good. Yeah, I think a lot of the school districts in Franklin have their kind of own schedule for food, and if it's, my understanding, it's 18 and under and no questions asked kind of for food delivery for those kiddos. Yeah.
That's my impression.
Perfect.
Lindy, I just have a question about that, and I don't know if you know the answer to this, but do you know if when they're delivering those meals, are they leaving them on the porch? Are they having contact with everyone that they're delivering meals to?
They're leaving them on the porch. They're using good hygiene. They're making sure they're not coming in contact. They are washing their hands. They are worried about themselves spreading it, but they're being very cautious about it. There was an article in the newspaper, if you'd like to get. That's how I know about what their procedure is. If you'd like to read that, it's in the Adirondack Daily Enterprise.
Thank you.
Also, Bob Ross of St. Joe's indicated that he is willing, he thinks that he can have volunteers for doing things. I don't know if they're up to what you would like to have done. I don't know if it's his staff or if it's the people who are in the vet center, but he is using his vans to deliver food and materials. So that might be a resource to you.
Do you have a contact number for Bob?
Yes, I do.
Yeah, I do. Hold on.
Because I do, they may be extremely resourceful if we come across someone who is in isolation that may have some addictive behaviors that may be difficult for us to deal with, and he may be a really good resource.
I think he would be, and I think that he probably also has his staff of counselors and nurses that can perhaps step up and make some calls. His office number is 518-891-3310.
Thank you.
And tell us if you want us to also keep reaching out to try and find other people. At this point in time, you know, you're the people that we're supporting and what you need us to do. And if you need additional help, there's other people who are saying, hey, I'm retired, I don't have my license still, but can I do something? I'm assuming they could probably make phone calls too.
Absolutely. Please do. Anything else from the phone?
No, thank you.
Okay. So we will definitely be in touch. Like I said, right now, and through the weekend, we are all set. So we will be reaching out next week, okay?
Great, thank you.
Super.
Take care. Thank you, everybody.
Thank you.
Thank you.
Good luck.
Thank you for what you're doing.